Yes, sir, you can start.
Sabir, should I start or you? Who is opening batsman? Okay. Actually, I will start. Good evening, everybody. On this 9th episode of Maha Subspecialty. And today we are blessed with the very senior pediatrician and rheumatologist, Dr. Raju Khubchandani sir from Mumbai. And he said he's going to do some different things on this diet today. And all of you know, we are probably missing some rheumatological conditions. We are usually suppose a set pattern patient is present. It's okay, we'll able to diagnose and recognize it. But sometimes we get hit wicket and maybe we diagnose quite late and our pediatric patient suffers. So all are very eager to hear sir for their pulse in pediatric rheumatology. And here is I thank Kunjan sir at the onset and to Samir Sadawarte also for the every time we both are manages, but all communication to all faculties almost 100% done by Samir. So thanks Samir for because we are going to end of the year and may we plan a big CME of the subspecialty later. A lot of ideas in the mind. So over to Samir again. Samir, please.
So thanks to our convener sir Jai Kumar ji.
आवाज
Actually, hello.
अभी आपका आवाज कम आ रहा है, थोड़ा बढ़ा दीजिए.
अभी आवाज आ रहा है?
Yes.
Okay. So thanks to Jai sir, who is the convener for this program, and the mastermind, our president Dr. Hemant Gangulia sir, and with secretary Amol Pawar sir. So this will be the 10th subspecialty chart today. So far we have finished like a rheumatology, oncology, nephrology, and so many others. And today is a very specific day for us that we have with us Dr. Raju Khubchandani sir. I know him personally from last 20 years. I starting my career in Mumbai as a MBBS part and later on. And I have seen so many cases he has handled so well. And whenever you call him, he is always available, maybe in the night also. Whenever you call him, if you will not find any answer for particular patients, clinical conditions, possibility of rheumatology cannot be ruled out. So something about the Khubchandani sir, he is a founder member and he is the rheumatology chapter of India. He started it way long and is one of the pioneer for the rheumatology services in pediatrics. He is passionate for the joint, muscle and bone, and thus it will be the rheumatology part. He has been trained in the Ghosh Hospital and has trained almost 15 senior doctors who are actually working only as a rheumatology across India, and they are practicing as a only rheumatology part. So teaching is his passion, and he has more than 50 presentations across the globe in Mumbai or in India in number, even in the thousands is that number. So thanks to Khubchandani sir for coming here today, and with his wisdoms, we are getting some more wiser things today. So over to you, sir, for next 1.5 hours.
Okay. First, even Dr. Hemant, our president, want to bless this evening. Hemant sir.
Thank you, Jay. I am traveling. Probably the noise will be disturbing you. But good evening and namaste to all the respected dignitaries on this Zoom dais and off the Zoom dais, all Maha IP office bearers, Maha IP team. I am extremely thankful and heartfelt thanks to Dr. Jay Bhandarkar and Dr. Samir Sadawarte to carry out all these episodes of Maha Subspecialty Connect each on second Friday of every month. When we our presidential action plan, we declare to have this 9 episodes of Maha Subspecialty Connect. Also, I would like to thank Dr. Neha for wonderful WhatsApp messages, as well as Dr. Vishal for appealing flyers, as well as Dr. Pallavi Madam, all technical support Zoom he has given. And regarding sir, we are really fortunate to have a great teacher. And I remember my husband days when I was a student under Dr. M.D. Shah, and sir used to come to the ward number 1 at a KM hospital. And so I remember, sir, your dedication, your devotions towards teaching, and I still remember those days. Thank you for gracing this occasion, accepting our invitation on behalf of Maha IP. I really thankful, sir, for a gracious presence, and I'm sure we will be hearing from you the pulse of rheumatology, which will be helpful in our general practice as a general pediatrician. Thank you very much. Thank you, Jay. Thank you, Samir. Thank you, sir, very much.
Thank you, Hemant sir. Dr. Amol, our honorary general secretary of Maha IP, please do give some of your blessings for this program.
Actually, the blessings are same like Gangulia sir. This is a very good initiative taken by Dr. Samir Sadawarte sir and Dr. Jay Bhandarkar sir in in each other's company. And I welcome Dr. Raju Khubchandani sir to this platform, to this webinar of organized by Maha AP. I welcome all the delegates and without wasting time, I request Jay sir to start the session, and delegates might be eager to hear something new about rheumatology by Raju sir. Thank you.
Yes, thank you, Amol. Before starting, I must acknowledge the efforts taken by Dr. Vishal Raut from Raigad IP as well as Neha Singh, doing wonderful job of this all flyers and messages and all coordination. And as well as Pallavi, madam, she's a digital I can take a support for this all Maha IP program. Thanks all of you. Whoever is associated with this program. So even I try to take the blessings from Dr. Mahesh Moite. Is a critical care this IIP chairperson as present. Moite sir आहेत का तुम्ही?
मोहिते सर जॉईन झाले होते.
आहेत.
हा मोहिते सर.
Good evening all. Khubchandani sir, nice to see you after a long time. Actually, I saw that flyer and I had kept that date booked on my calendar. I just cannot miss his talks. I just cannot, because every time I go through his talks, I get at least 5 new points in the lecture, and definitely something which can be applied very next day. So thank you very much, Maha IP, for this opportunity. I'm sure this is going to be a wonderful talk. I'm really looking forward to it. Thank you very much. Thank you.
Okay, so I think we should Samir, we should start the session. Thank you.
Yeah. So we'll hand over to Khubchandani sir for his next proceeding. So we can make the sir the host. I think he's already host. Khubchandani sir, you can start your talk.
So, friends, I just feel so overwhelmed and under such pressure to perform today. It is as if I'm going for my MD exam. With so many good, kind words being said, it becomes most imperative that I do not flatter to deceive. Samir, when I asked him, Samir, what would you like me to talk on? Samir was very, very clear. He said, sir, we are giving you a blank canvas. You paint on it the way you want. Please give me a moment so that I can switch off my cell phone, because otherwise it will bother us again.
Sir, you got mute actually, I think.
Sir, ते फोनवर बोलतायत, मग नंतर लगेच जॉईन होतो.
Okay, okay.
देना तो blazer.
So, I was quite in imagination as to what I should be doing for today. And let me tell you that I have crafted something quite special. What we are going to be doing is that I have created a picture quiz in rheumatology. The rules of this quiz are very simple. There are about 28 or 29 photographs, each of which has got a small caption like you would see in a crossword puzzle. Please take your paper and pen, and we'll give you 2 minutes to grab some paper and pen. And everybody, the uniformity is write slide number 1 and write your diagnosis. Each slide will move automatically after 11 seconds. effectively in about 3.5 to 4 minutes, the quiz will be complete. After that, there will be a 3-minute break. You will take a photograph of the answers that you have written and put your mobile number and your name on that paper and WhatsApp it to me. After that, I will proceed with my talk, which I have prepared for today. Once the talk is over, we will go back to the quiz and I will release the answers for the quiz. We would then realize who has got the maximum correct, and there is a surprise waiting for that person. Samir, are you okay with this concept? I can't hear you.
Hello. I am
Yes.
so happy that it will be the one of the best way to know and judge yourself first time for us. And then
Yeah.
yes, so I agree. for
And it is entirely voluntary for people
Yeah.
to participate. Even those who are on YouTube can participate. No issue at all. And it is voluntary. If you wish to do the quiz by yourself but not submit answers, that is also okay. But if you wish to compete for an award or a prize, which is going to be a surprise quiz, a prize, which I will announce at the end what the prize is. But who has got the prize, it will take me a day or two to verify on the medium, which I will be telling you where to send the answers. So I hope this is clear to everybody who has joined, and I therefore, okay. Yeah, yes, Samir.
Sir, maybe you can put your email address so that people who are listening can send you email also.
Absolutely. Absolutely. So Dr. Pramod Kulkarni has requested that I repeat the format. I will once again state how this will work. There are 29 slides with photographs on them. Each slide has a clue, and that clue is like a crossword clue. Each slide will stay on the screen for 11 seconds. All those who are on YouTube or on Zoom Live are invited to participate. Please take a plain white sheet of paper and write your name and your mobile number in one corner. After that, what you must do is stand by for the slides and go and writing the answers. Once you have written the answers, we will then give you 5 minutes to take a picture of your answers and either send it to me by email, having scanned it, or by WhatsApp. After that, I will move to my lecture. The slides will take about 3 to 5 minutes to roll off. Only those responses which have been received before my lecture is complete will be deemed as the responses submitted for the competition. After the lecture is over, I will reveal the correct answers for purpose of those people who chose not to enter the competition but were just keen to do a self-assessment. I hope I'm clear to everybody. My email is not yahoo.co.in. My email is rajukupchandani@gmail.com.
Okay.
rajukupchandani@gmail.com, and the mobile number where you could send your responses by WhatsApp is 98210 9552. So is everybody got their paper and pen, and is everybody ready to go? Now give me 5 seconds to allow me to share screen. So folks, I'm going to be sharing screen very shortly, after which the timer is out of my hands and each slide will move every 11 seconds. So please grab your paper and pencil. This is your last chance. And here we go.
Chennai, Anil Kumar, Secretary Co-host. Members in this game. Pooja Sister, Billa Verma, Mumbai.
So, friends, that was the end of the quiz.
It was too fast.
That was the end of the quiz round. After this quiz, I'm going to be moving to my talk. But before I start my talk, what I would request everybody to do, those who wish to participate in the competitive part of the quiz, kindly all the answers that you have written on your sheet of paper, please write your name on that sheet, take a photograph and send it to me either by WhatsApp or by email on 9821095552 or by email on rajukupchandani@gmail.com. If you send it to yahoo.co.in, you may miss your prize. So now I have to only say one thing, that people who have worked with me as residents or fellows are not allowed in this competition. Okay? So Anushka, Pranav, Prajakta, Chetna, all are disqualified. So with this now, we move to my talk. So I was just thinking about what would fascinate a bunch of erudite Maharashtra pediatricians. And I just thought that showing pure rheumatology is probably rather boring, because no patient comes with the label of rheumatology written on his chest or shoulder. We get a mixed bag of cases, and therefore several people like to call rheumatology actually musculoskeletal medicine. And therefore we see total rheumatology cases, but we see such a mixed bag. Therefore, what we are going to be doing is, I'm going to show you 10 cases, each of which will have a great lesson for you. And I will be going at this pace for my talk, very slowly, so that you can imbibe an issue and ask whatever questions you have later on through the chat box, which Dr. Jaikumar, Dr. Samir, or Dr. Amol will moderate. Because some questions may overlap. Those who are on YouTube, I don't know how you all can ask the questions, but perhaps the organizers will help you out with that too. Again, give me 10 seconds to be able to share my screen.
The YouTube question also will be posted here, sir, on the chat box. So I made that provision.
So now I'm going to be sharing my screen yet again for my talk. And I hope that I'm quite audible and visible. So I've chosen to title my talk as 10 Tricky Treats. Before I begin, I have a sincere request. All the clinical pictures in this presentation are from my personal collection. They have been published or are in the process of publication. And therefore, taking screenshots, pictures of the screen, or reproduction in any form is very strongly discouraged. So let's start with this very first case. This is a 16-month-old female who I saw. And in 3 to 4 months, she has had about 7 or 8 kilos of weight gain with excessive hair growth all over the body in the last 3 to 4 months. There is a history of perianal rash since infancy, no other past medical or surgical illness, and her birth weight was 2.5 kilos. Development and immunization are appropriate for age. Her NIBP is 82/61. She has a Cushingoid facies. She is hirsute. She has an erythematous rash on the flexural areas. But there is no axillary or pubic hair, no clitoromegaly, no adrenarche or thelarche. She weighs 17.7 kilos. Her length is 82 centimeters, which is okay for her age, and her systemic examination is normal. And this is what she looked like. If you can see the picture on the 4 extremes, and the picture in the center shows you what she looked like on her first birthday, which the mother dug out from her records or cell phone, I can't recall. So the first thing I do is an 8 a.m. cortisol. And what do I find? The 8 a.m. cortisol is less than 1 microgram. And then, even as we are trying to see whether we should do the low-dose dexamethasone suppression test, we find the ACTH is 1. And therefore, we immediately realize that here the pituitary is suppressed. All the other hormones are entirely, the other virilizing hormones are all normal. And so therefore, I'm very clear that I'm dealing with iatrogenic Cushing syndrome. So we go back to the mother and keep asking her, what medicines are you taking? And here's the story that emerges. She's been using a topical steroid cream locally for rash in the perianal and flexural surface of the neck and axilla for 5 to 6 months. The mother has continued to use the same for around 4 to 5 times a day. And she says she uses 2 fingertips each time per application. And she used 1 tube in 4 to 5 days. 15-gram tube and 30 to 35 such tubes had been used by the mother. And the child was exposed totally, therefore, to about 400 milligrams of clobetasol propionate. It therefore is a very important learning point for me when I saw this patient. And I went back to read when we use topical steroid therapy. The first thing to consider is which preparation are we using? We are very used to recognizing that dexamethasone is more potent than betamethasone, is more potent than prednisolone, is more potent than hydrocortisone. But where we forget that even in topical steroid creams, there is an hierarchy. Clobetasol propionate is at the highest. Your mometasone and desonide come midway, and your hydrocortisone comes at the lowest rung of the story. It is a crime to use clobetasol propionate for more than 2 weeks at a stretch at any point in time. So the other point is, are you using a cream? Are you using a lotion? Or are you using an ointment? All these 3 are different stories. Speak to your dermatologist friends, or go back and read a little more about this to understand the difference. What part are you applying it to? If you are applying it even on the eyelid, you can create glaucoma in the eye if you use a high potency steroid. If you apply it near the genitals, all the thin skin, the neck, then the absorption is significantly higher. And lastly, what we always say, oh, just use this ointment. For syrups and tablets, we invariably say 1 tablet 3 times a day. I think it is important for us to start saying, even for ointments and creams and topical applications, 1 fingertip unit, FTU. That is how all dermatologists' prescriptions should be ideally written. And last but not the least, while we do realize that we should give prednisolone at 8 in the morning, similarly, as and when you are using topical ointments, similar rules apply. So this was the takeaway, where I saw a child with systemic steroid toxicity following topical use. Moving to case number 9, and I'm following something like a Binaka Geetmala, where I will show you the absolute apex case at the end. Now, this is a 5-month-old male child who comes with fever for 2 months, irritability, and excessive crying. There are no other localizing symptoms. Hemodynamically quite stable with a puffy face and pallor. All other systems are normal. And when you see this child, immediately what will strike out to you is that the face looked rather puffy. I recall that I saw this child reasonably early in my career as when I did a mid-career shift towards working more and more in pediatric rheumatology. And this was perhaps amongst the first children who was referred to me by the great Dr. M.R. Lokeshwar. And what did I notice? Anemia, a raised white cell count, marked thrombocytosis, elevated CRP, and a mild elevation of ESR with a borderline low serum albumin. Now, I was very intrigued by the puffiness of the face, and therefore I proceeded further. These tests were not done by me, but had already been performed before the child was referred. And indeed, when we took an X-ray of the face in the AP view, you can see this mandible is rather thickened, what you would call mandibular hyperostosis. So what did I do next? I got a bone scan done. And can you see how the mandible has lit up over here? Completely dark over here, the mandible, which helped me to confirm and clinch a diagnosis of Caffey's disease, something called infantile hyperostosis. There are 2 forms of Caffey's disease, the mild infantile form and the severe form with prenatal onset. Most often it hits flat bones. The mandible is a very preferred site. The long bone, the ulna, and rarely at other sites. So uniquely, Caffey's disease can be self-limiting. All that I did for this child was give 6 weeks of NSAIDs, and very glad to note that the child responded beautifully. The family, I think the mother is a medical practitioner somewhere in Pune, and the story ended quite happily. Going to case number backwards 8. Now, this is a 12-year-old female with right-sided pedal edema, gradually increased right up to the knee. Most importantly, it's a non-pitting edema. And there is a left-sided pedal edema for a few months. No systemic features, no relevant family history at all. Please note her age. And I hope you are able to appreciate the edema of her right leg. And you will have to believe me when I said that this edema was non-pitting. So my working diagnosis was lymphedema, but there's no filariasis setting, there's no fever, etc. And therefore, I went ahead and did a lymphangioscintigraphy and was beautifully rewarded. If you can see this limb and this limb, in this limb you can see the radioactive dye going all the way up. While in the contralateral limb, you see virtually no dye at all. And this immediately said that, okay, there is a lymphatic block over here, and this is the name of the entity. It's called lymphedema precox, also known as Meigs disease. So let's look for 30 seconds on what this story is. You have primary lymphedema. If it's congenital lymphedema at birth to 2 years, remember in this setting, you will always consider Turner's syndrome or Noonan syndrome. Then around puberty, if you see this thing coming, it's called lymphedema precox. Remember that our child was 12 years old. And lastly, if you see it coming at an older age, it's known as lymphedema tarda. Now, lymphedema precox is an autosomal dominant condition. And basically, this is the gene that gets inactivated. And uniquely, it's seen many, many more times in females as compared to males, thereby raising a speculation, because it comes during puberty, that estrogenic hormones are probably a second hit. The management is conservative. You unfortunately cannot do anything. Skin hygiene is paramount, because these children, if they get a small cut, a wound, or a bruise, their lymph keeps oozing and they get nasty cellulitis. You have to avoid tight clothing or trauma to the area. Surgical methods do exist, but I have no experience with this story at all. Fibrosis of the limb tissues, and as I said, cellulitis is a major story. Literature reports lymphangiosarcomas. Going to case number 7. So this is a 6-year-old male with an acute onset, but then a slowly progressive occipital and nape of the neck swelling for the last 8 months. And basically, 4 months later, there's a progressive bilateral shoulder restriction of movement, sees his primary pediatrician, and this primary pediatrician does an MRI of that mass and sends it to a pediatric surgeon, who then says that this is something which is not in my realm and refers the child to me. And this is what you see the child looking like. There's an occipital swelling, which you can't see here, but I'm sure you can notice the asymmetry of the back over here. You can see this scapula is quite prominent, and you can see where my pointer is, that there is some kind of a mass effect over here, and some degree of scoliosis, with this side a lot more prominent than the other. And this is firm in consistency. It's non-tender, and the movements are restricted. And the MRI has already been done before the patient was brought to me. And you can see these sheets over here, which are beyond the vertebral column. You can see these sheets over here, and I'm going to let you into the story in a moment. If anybody has guessed the diagnosis, well, this was the giveaway. And therefore, as I always say, sometimes looking down in humility at the floor can also give you a diagnosis. And that is, please note that this toe, the great toe, is shorter than the second toe. Now, while in our Sindhi community, when you get married and when you are entering the door of your husband's house, they look at the toe size to decide whether the boy is going to dominate the marriage or the girl is going to dominate it. But here, however, the connotations are different. This is a classic, absolutely classic sign of what is called fibrodysplasia ossificans progressiva, FOP. Previously, it used to be called myositis ossificans progressiva. The great toe is a clincher of the diagnosis. You do not need anything else at all. There is progressive heterotopic endochondral ossification, neck, back, and shoulder, minor blunt traumas, intramuscular injections, mandibular blocks for dental work, muscle fatigue. All these can trigger a new flare. You have to be very cautious, and this is an unrelentlessly progressive disease. Invariably, the patient gets encased in another skeleton and he asphyxiates very slowly and progressively to his demise. So the turning point here was the short big toe. The learning points here are awareness about FOP, congenital malformation of the great toes and episodic soft tissue swelling. 90% of affected individuals have been affected worldwide. I am really very proud to say that after this first case was shared with my residents, we have seen, I think, 3 or probably 4 more patients with a similar story. And each time it has been picked up by them, straight away identifying this particular sign. Do remember this entity. Case number 6. Now, this is true rheumatology. This is a 13-year-old female. She comes with prolonged fever, autoimmune hemolytic anemia, and pulmonary hemorrhage. The diagnosis is lupus. She's on regular therapy, and suddenly she comes with abnormal movement since 3 days. She's hemodynamically stable. Power is 4/5 in the left upper limb and lower limb. Reflexes are brisk in all 4 limbs. And I'm sorry, but I was unable to show you the video here, but this child had left-sided hemichoria. Now, our MBBS teaching is chorea means rheumatic fever. Not true. To me, chorea invariably means antiphospholipid antibody positivity with basal ganglia involvement in lupus. C3 and C4 were low. We'll skip this MRI, but I want to show you something. Can you see these basal ganglia over here? This was performed a PET CT to show you exactly how the basal ganglia light up in this APLA positive condition. In the rheumatology OPD, I would have seen perhaps 5 children with movement disorders, but my mind goes back to the most fascinating one we saw last year, who had COVID-induced APLA with chorea. So COVID can do strange things, and this was infection-induced APLA. Movement disorders in lupus are rare, but in those, chorea is the commonest, and this can be the first clinical manifestation of lupus. Going over to case number 5. This child came from Aurangabad. Recurrent fever, easy fatigability, thickening and swelling of the skin over the right upper thigh. I've drawn an ink mark around to show you the indurated area, and you can see that somebody has performed a biopsy here and also a biopsy here, which was taped up before the child was brought. This is a febrile, pale, sick-looking child. Peripheral pulses are well felt, and there is this sharply demarcated indurated lesion which I showed you. Hemoglobin is just 5.5. 25,000 is the white cell count, and this is the platelets with polymorph dominance. And this child had been labeled as morphia and received steroids and methotrexate. Any thoughts or differentials, keep them in your mind. We got some imaging done, and please note that there were these plaque-like lesions right over here surrounding circumferentially and lighting up over here. Subsequently, we got a biopsy done, and the most unique aspect was that when we stained it with a special stain, there were fungal hyphae, which let me try and show you here, and a diagnosis of a subcutaneous zygomycosis was proposed. We were so foxed by this whole story that we went and started reading more. And thanks to a report by Dr. Uday Khopkar, a respected, very well-read dermatologist, we found an article that said that this type of fungus is endemic in Maharashtra, and it is seen in the soil, in the farms. And what therefore had happened was, we discovered later, the child had had a fall while he was in the farm with his father, and probably that was the source of inoculation. What were the lessons we learned? Think before starting steroids. And before you start steroid, make sure you've ruled out infection. And the diversities in spectrum of diseases in rural and urban settings can lead to a delay in diagnosis of maybe not such an uncommon disease. Case number 4. This is a 3-year, 4-month-old female born of a 3rd-degree consanguineous marriage. And this child develops a gradually progressive bent 3rd and 4th finger of both hands for a year and a half, not painful, and swelling of both wrists and knees. And what do we find? The joint is very boggy, very bulky, but absolutely cold. And the range of motion is complete. Other joints are normal. You can see this joint over here, boggy, bulky joint, and you can see this bent finger. Now, what do? Acute phase reactants normal, ANA negative, eye examination normal, 2D echo normal. We take an X-ray of the hips. Can you notice this very short femoral neck? This femoral neck is almost absent. Remember this. This is normal, 120 to 135 degrees. The moment it is more horizontal, this is coxa vara. And the moment it is more than 140, it is coxa valga. Since actually we had made a diagnosis at this stage, but I was academically inclined and I did a synovial biopsy because these were days when genetic testing was not available. What you will see in this synovial biopsy is these giant multinucleate cells. If you can see one here, and I'm going to show you another one on high power. And these giant multinucleate cells are CD68 positive. And this is absolutely pathognomonic of camptodactyly arthropathy coxa-vara pericarditis syndrome. It's called CACP syndrome. There is no treatment available for it, but it is believed to occur because there is a certain protein by the name lubricin, meaning to lubricate, which is absent in the synovial fluid. That gene codes for lubricin, and it's an autosomal recessive condition. And very uniquely and peculiarly, I have seen about maybe 5 or 6 patients. All of them come from the Hubli, Dharwad area in that particular zone. Now, this may be a bit of a referral bias, but it may also be the fact that that area consanguinity is a rather common practice. This is a 5-year-old male, onset at 3 years of age, episodic limp every 1 to 2 months, lasting for 3 to 5 days. No other systemic features. Slightly overweight, hypermobile, flat feet, and the right leg is more everted while walking. Now, here you see there is a coxa valga, but my good friend Dr. Aditya Daftari, who practices exclusive rheumatology, rings up most excitedly and says, "Can you see this area? This is ischiopubic synchondrosis." This here again shows me in a picture over here. And this ischiopubic synchondrosis is also called Von Neck-Odelberg disease. Now, it's not really a disease. It's a normal variant of the developmental process where basically these bones should have fused a bit earlier, but it can give rise to symptoms. But these symptoms invariably come after vigorous exercise and are short-lasting. The treatment is to reassure the parents and send them home, not giving any medication at all. Coming to case number 2. So this is a 7-year-old female, right upper and lower limb swelling noted since June 16. Mother noted some hardening and color change on the right side compared to the left. No diurnal variation, no fever, no systemic symptoms. Vitals are stable. Peripheral pulses are well felt. The right limb is warmer than the left. The skin over the limb has a faint pigmentation with a sharp border. And there's a 1 centimeter difference in the girth. There's no pitting. Trunk and face are normal. There's a mild contracture of the right hand, slight pain on movement of the PIPs. And this is what her hand looks like. And you can see this slight pigmentation over here. And you can see the slight difference in the girth, perhaps. My working diagnosis is lymphedema, but I'm not convinced. Phenomenally cooperative family. They still follow up, and I saw this child just about only a week ago. Doppler is normal. Screening MRI is done, which I will show you. But this diagnosis, I must credit my previous fellow, Dr. Prajakta Joshi Ranade. She was sitting across me, and it was one of those days where she had a eureka moment. And she says, sir, her absolute eosinophil count is greater than 1500. There's a mild ESR elevation, and there is hypergammaglobulinemia. Why are we not dealing with eosinophilic fasciitis? And when the MRI is done, you see this streak of fascia lighting up. Now, this is actually one of the forms of localized scleroderma, if you may say, and the pigmentation of the skin above was part of the same story. I'll skip this and just again show you what's happening in the fascia over here. This was to show that there is no fat atrophy, and the diagnosis of eosinophilic fasciitis known as Schulman syndrome, female predilection, most common forearm, leg, hand, and feet. She was started on steroids and methotrexate. She recovered. We stopped the drugs, and the problem relapsed again. And that's the reason she still continues to follow up in spite of it being almost 3.5 or 4 years. But they are a steadfastly loyal, understanding family. And this is one of her follow-up pictures. And now I come to the crowning case of the day. This was one of the days that our team worked in such rapid synchrony and with such a rapid thought process. It was a kind of a day where we were all having a eureka moment. This case eventually was submitted for the annual K.C. Chaudhary Awards, which is held every year at the All India Institute of Medical Sciences, and was presented there by Dr. Kritika Malhotra and Dr. Pawan Reddy. And we were the only private hospital in that entire long August list of people submitting. And I'm very proud to say that both my residents then did us really proud by winning the first prize for this case. So please listen on very carefully. This is an 11-year, 7-month-old female who comes to her primary pediatrician with vomiting for 3 days, bilious vomiting, generalized continuous dull aching pain for 8 days, and a slowly progressive abdominal distension for 2 years. On examination, she has an abdomen which is significantly distended, an everted umbilicus. The liver and spleen are not palpable, and the bowel sounds are absent. Please note the bowel sounds are absent. This is her X-ray abdomen erect, and this is her sonography abdomen of the pelvis. You can see multiple fluid levels over here, and the sonography of the pelvis shows a massive ovary with cysts in it. The MRI abdomen and pelvis are done, and again, it shows multiple ovarian cysts and dilated small bowel loops, as you can see over here. And these are your multiple ovarian cysts with a large ovary. Now, this patient is admitted under our dear surgeon, Dr. Ketan Parikh. But Ketan, being extremely smart and not wanting to act in a hurry, senses that there is a rat, and sometime at 12 in the afternoon, before posting the child up for surgery, makes a pediatric reference to me. When I go in and see the child and review the previous reports, what do I find? I find that this SGOT is slightly elevated. The creatinine is high. The hemoglobin is just 8.1. Everything else looks pretty normal. But what strikes me is that if this were a surgical intestinal obstruction, then I should have been seeing hyperperistalsis. Here, on the other hand, I'm seeing complete ileus, and this worries me. So I create a problem list. What is my problem list? Intestinal obstruction with an ovarian mass and raised creatinine. Now, how am I going to break this puzzle? So what we start looking at is there is a puffy face. There are puffy fingers. And then we start asking the mother more. There's chronic constipation with progressive abdominal distension. The growth has been flat for the last 18 months. And the mother has noticed scanty spotting since a year. So she believes that she has started menstruating. There is decreased appetite and lassitude. She attends school, but very listlessly. Now, what do we find? The skin is absolutely dry. There's acanthosis nigricans. And please focus on this. This growth chart has been skirting the left of the road, but has flattened off late, as you can see. But her weight has gone up pretty significantly, and her BMIs are going up pretty significantly. This is what her abdomen looked like. A smiling umbilicus, ascites, absent bowel sounds, and most importantly, there's a delayed relaxation of the deep tendon reflexes. You don't need a rocket science to say that this child was hypothyroid and the TSH came sky high by 4 in the evening. So now we said we have a very elevated TSH. But what does that have to do with an ovarian mass? And there the credit goes to Dr. Pawan Reddy, who was working with me and by then had got so charged with the diagnosis of the fact that we had picked up hypothyroidism within 3 hours of the patient arriving, that he phones me in the evening and he says, "Sir, this patient has autoimmune thyroiditis because all the thyroid antibodies have been elevated." I said, "Excellent." So then what is our problem list now? There's subacute intestinal obstruction, there's adynamic ileus, there's a deviation in the growth curve, puffy face, dry skin, constipation, ascites, and a raised serum creatinine. So it's pretty easy for me to explain 1, 2, 3, 4, 5 on the basis of the hypothyroidism. What about the raised creatinine and what about the ovarian mass? So we said, I always believe lightning always strikes only once at the same spot. Try and always get everything under one umbrella. So we went back and said, can hypothyroidism raise creatinine? And the answer was yes. Hypothyroidism reduces the GFR. Hypothyroidism also causes myopathy, and these can be mechanisms for a mild creatinine elevation in hypothyroidism. Now came the major issue. How do I explain the ovarian mass? So, the ovarian mass plus hypothyroidism is something that is referred to as the Van Wyck-Grumbach syndrome. Now, what the hell is this? This was first described by Van Wyck and Grumbach, early 1900s, hypothyroidism with an ovarian mass and precocious puberty. Now, uniquely, the LH was less, the FSH was okay, the estradiol was this, the HOMA index was elevated, and the CPK was 130. Okay, mildly elevated by that laboratory standard. And the elevation in CPK and the SGOT were explained on the basis of the thyroid myopathy. And we did a pituitary scan to show a huge pituitary fossa mass. I'm coming to this, suggestive of a pituitary so-called adenoma. This was actually hyperplasia of the pituitary because of the hypothyroidism caused by antithyroid antibodies. We started thyroxine replacement, metformin, lifestyle modification. Within 6 weeks, the child was almost back to normal. And on follow-up, at 1 year, the TSH was 1.23 and the ovarian mass had almost disappeared. Now comes the question which everybody will have. What is the story behind this? The story behind this is that TSH and FSH act on a receptor in the ovary, which is very similarly responsive to both. So that poor receptor in the ovary cannot recognize whether this is TSH or FSH and starts creating ovarian estrogen. This leads to ovarian follicular cysts. It leads to the pseudo menstruation you saw, and it leads to the breast development, but there is no pubic or axillary hair which is formed because this is coming only from the ovarian axis. Okay. Now, so this could be looked at as a hormonal overlap syndrome. And therefore, Van Wyck-Grumbach syndrome has been called the syndrome of paradoxes. It is a syndrome where normally in hypothyroidism, you get delayed puberty. Normally in hypothyroidism, you get hair loss. And with delayed puberty, you usually have delayed bone age. But in Van Wyck-Grumbach syndrome, hypothyroidism does not equal delayed puberty. In fact, they have pseudo-puberty early, does not cause hair loss, and the precocious puberty is associated with a delayed bone age. Before I end, just to say to you that I run this online course in pediatric rheumatology. My next batch will be starting on the 16th of November. It's 10 lectures, each lecture is about 90 minutes to 120 minutes. And there are two formats I have. One is called Promise, which is the 10 sessions. And the other is a monthly single session where we discuss just cases which the delegates send in. You may kindly visit my website and look at more details on the format. And if you desire, register for it. So friends, let me end by saying that rheumatology is a mixed bag. You saw, I showed you some cases with musculoskeletal features, some cases with autoimmune diseases, but each of them had a very, very clinical slant to it. And therefore, it's so full of mimics that if you step out of your house in the morning and see something like this, you'll wonder that there's a tiger lying on your footpath. But if you go nearer, you realize that it's just your friendly neighborhood dog. So what we therefore invariably land up doing in rheumatology is very fascinating. There are several children with musculoskeletal complaints. And then I'm sure all of you have seen this in your kitchen. We filter out the rheumatological illnesses, which are only these 7 or 8. We don't know anything more than this, and refer the rest to their appropriate specialists. Thank you very, very much for a most patient listening.
Thank you, sir. So fascinating cases, and I think Samir, over to you.
I'll just put on the air conditioner and be back.
Hello. Able to hear my voice?
Yeah. थोड़ा कमी है.
Yeah. But like there are I thought it will be like a sir will talk about the rheumatoid arthritis, rheumatic fever, something like that. This is hypometrophy, coxa vara, fasciitis, eosinophilic, Van Wyck, Grugenberg. All these are like a very high to my height actually, but they are very interesting actually because you make the diagnosis what we thought of initially like a surgical case or like a metabolic case. It comes so differently. So I personally feel sometimes that if you're not able to diagnose somebody particularly, at least take some opinion from the rheumatologist also. It really works many times. And I remember Vishwanath sir with us some time ago, and he did diagnose certain of the very rare of the cases so nicely. And he used to talk about his teacher, that's a Kupchandani sir, every time to us. So thanks to Kupchandani sir for this wonderful talk. And now audience is open for the questionnaire. See if somebody has something.
Anybody can just start the video and you can ask questions directly to the sir.
Yeah.
I think we have some time for this. I think everyone is so mesmerized with this session. Fantastic cases. And even sir, many cases were cracked by the audience in the chat box also.
I saw a few names there.
Even I'm just going through the chat box and I'm very, very deeply impressed. That almost makes me feel that I have Naresh Taide there who diagnosed CAFE, Pramod diagnosed CAFE. Then Renu Boralkar talks about lymphedema. And so many. Then I have Bharti Khairnar on CACP. They know all the time. And of course, Narendra Nanimdekar can never be far behind.
Nanarika sir, ahat ka? Narendra sir.
Yes, I'm there.
Video on kara चालतंय.
Only thing is, I joined late, so I couldn't see the quiz part of it. I was initially thought that there's some technical problem. Sir was sitting quiet and all the slides were going on. So I came halfway through.
So you missed the quiz?
Yes,
These are
yes.
more interesting, I think.
Yeah.
I am very sure I answered 5 of that question out of 20, 100%. They are correct.
Great.
But 23 I cannot answer.
So what I'm going to do now is very rapidly give the answers to the quiz. And the first thing I have to say is that if anybody still has to send in their answers, the time now is 10:19. So only answers received before 10:20 will qualify for the prize.
Whatever thing we just send it so that at least even if you can able to answer, even concession price is also there.
So there is just one prize I'm going to announce, and that is a complimentary registration for Promise on on the 16th of November. That will be the prize. If somebody has already done promise, he or she could gift that to anybody of his or her friends. So now give me a moment and I'll very rapidly announce the answers.
Sir, एक minute, sir, एक minute. Yes, चलेगा.
So just one thing I'll also send. I sent to Kuchandani sir in the email.
थोड़ा सुपर फास्ट था, सर ज्यादा ही सुपर फास्ट था, थोड़ा लिखने में ही गड़बड़ हुई.
RAJU.
gmail.com. भेज दिया.
So may I say that at 10:21 or before, all answers received are deemed as received. After 10:21, nobody will be entitled to the competition.
चलेगा.
So I'm starting my answers.
Yes, sir.
And I'll go through this rather rapidly because I'm sure everybody's spouses are either waiting for dinner or waiting to wrap their spouses on their head as to being awake for so long. So the clue here was a rather tall child with a father who wears -9 glasses. High myopia in the father. What you see on this X-ray here is something that is called protrusio acetabuli. And this is the commonest manifestation, orthopedic manifestation of Marfan syndrome. So you see a tall child with a hip involvement, which is non-inflammatory. Think of protrusio acetabuli and Marfan's. This is straightforward nail pitting, which you see in psoriasis. Also seen in psoriasis is dactylitis, also called a sausage digit. This is a classic hand in a prolonged, uncontrolled diabetic child. This entity is called diabetic chiararthropathy. You see a mild hyperextension at the PIP and a flexion at the MCP and a flexion at the PIP. This is a very, very typical scenario. Make the child fold the hand and you see something like this. This is dental fluorosis. You have a child who comes to you from Rajasthan with these chalky white teeth and skeletal complaints. Think about the possibility of skeletal fluorosis, which can be a mimic of rheumatoid arthritis. This is Osgood-Schlatter's disease, typical of a 14-year-old male with an avulsed insertion of the quadriceps tendon. Punched out lesions, punched out skull lesions, histiocytosis with a collapsed vertebra. An intra-articular fracture over here. If you aspirate this joint, you may get blood, but not only blood, but you may get marrow fragments. to tell you that this is an intra-articular fracture. Many a slip between the cup and the lip. Okay, slipped capital femoral epiphysis. You see this femoral epiphysis has slipped downwards. There is a particular radiological sign for it, but you can see that over here also, that if you draw this line which goes from the neck, normally it should pass through the acetabulum. But if it doesn't pass through the acetabulum, it means that there is a slip. The classic story is of an obese adolescent male must be screened for hypothyroidism. And the other way around. If you diagnose hypothyroidism, must screen the child for SCFE. This is classic systemic sclerosis with the multiple joint contractures, ulcer, and pinched out nose with a lip which has been curled upwards, exposing the incisors. So Andy Murray and Maria Sharapova were once engaged, and therefore I've said these are Bose lines. Okay, these are Bose lines often associated with Kawasaki disease. However, it's not always with Kawasaki disease that you get Bose lines. It basically suggests an arrest in protein synthesis temporarily. It can happen due to various acute conditions. Even newborns with asphyxia neonatum have been found to have this. Typically is seen about 6 weeks after the insult. That's because nails grow at about 1 millimeter per week. There's only one cause of acquired micrognathia, and that is juvenile idiopathic arthritis. These are classic Gottron's papules, named after Adolf Gottron, the Polish dermatologist, and typically seen and a sine qua non for dermatomyositis. This is the calcinosis of dermatomyositis, and this is the heliotrope. A heliotrope is nothing but a purple-colored flower, the heliotrope rash of dermatomyositis. This is a child who was given unsupervised steroid therapy, who develops an osteoporosis and a vertebral collapse. This is a classic Turner syndrome with a wide carrying angle. Why I called it one short and a short one. Short stature and one short is one less chromosome, XO. Why these are important to us is that these children come with several autoimmune disorders. Hypothyroidism, celiac disease, rheumatoid factor positive rheumatoid arthritis, and the works. So remember, Turner syndrome needs rheumatological monitoring. If I told you that this child comes frequently, saying that while walking, his knee suddenly buckles, and he has an X-ray like this, you see the position of this patella is so very high. You're supposed to take this length from the top of the patella to here, and then take the length from the bottom of the patella to the tibial condyle where the quadriceps inserts. This ratio is called the Insal-Salvati ratio, which helps you to diagnose an entity called patella alta. Patella alta means high riding patella. And this is something that can cause the child to have a frequent fall because of patellar instability. This is a common mimic to a rheumatologist. You see this bone which has been eroded over here, and you see this story happening over here, a calcific mass over here. This child had a neuroblastoma. And neuroblastomas can present with almost a systemic GI-like presentation below 1 year of age. So whenever you see a child below 1 year of age, where you are considering the thought of systemic GI, pinch yourself twice, open your eyes thrice, have a cup of coffee 4 times, but do not diagnose systemic GI at an extreme of age very, very quickly. This is classic Perthes disease. That's why I said a city in West Australia. Epididymoorchitis is seen in 1% of children with enox-online purpura, calls for 1 mg per kg of steroid for about 2 to 4 weeks. This is archetypal arthrogryposis multiplex congenita. Therefore, I've said bend it, but not like Beckham. This is a syndrome. The moment you see a child with 20-digit clubbing, but no cardiac disease and no pulmonary disease, ask him whether his hands and feet sweat excessively. Ask him if he was born premature, and ask him if he was operated for a PDA. Then ask him if he has limb pains. Or if he has presented to you with limb pains and you happen to find clubbing, look for his X-rays and look for a periosteal reaction. This is an entity called pachydermoperiostosis. Pachydermo because they have a thick elephant-like skin and significant acne on their faces. This is garden variety lupus. This mucositis in a prolonged pyrexia should never be missed. Please note the sparing of the nasolabial folds. This is once again Caffey's disease. See the periosteal reaction over here. This is another form of localized scleroderma. It's a special form that's called Encou de Sabre, ENCOUPDESABRE, meaning like the injury caused by a sword. Okay, and this is a variation which can extend right into the brain and give rise to seizures in the child. This is a child with extreme hypermobility. You will see many children with W sitting like this. Hypermobility and intorsion of the femur. These are the 2 causes you must remember. This is nothing but a brachial plexus story. If you can see Porter's tip position. And last but not the least, this is a dislocated hip. You can see that this line has been disrupted on this side. Folks, thank you very, very much for a very patient hearing. I'm happy to take any questions, and invariably I tell myself if there are no questions, then either everybody has switched off or I have done a great job. Either of them.
Yeah. Sir, good evening.
Good
Hello.
evening, please.
Yes, sir. Dr. Mangesh from Pune. I have a question regarding the Caffey's disease case. 6-month child with irritability. What clinically suggests us that it is we look to Caffey's disease, because there can be other things for the irritability at 6 months. So how will go to Caffey's disease in this case?
So let me tell you that I have seen about 3 or 4 children with Caffey's. In the child which I showed you first, there was a mandibular swelling, which I chose to take an X-ray of. in the child, which I showed you in the subsequent, in the quiz, that child had a swelling of his tibia. Okay. Very often, when this comes in the infantile form, people are reminded about congenital syphilis. People are reminded about scurvy. Okay. But it's not that it will be irritability alone. There is always a bony manifestation which you see and pick up. The warmth of the bone or something of that sort.
Thank you.
Any other questions? Anyone from the YouTube who's asking questions? Just out of curiosity, what was the YouTube attendance like?
पल्लवी मॅडम युट्यूब अटेंडन्स करतो का? आहेत का तुम्ही?
तर प्रश्न नाहीयेत काही, फक्त कमेंट्स आहेत.
ओके, आणि अटेंडन्स कळतो का आपल्याला किती जण अटेंड करतायत?
So 85 are watching on YouTube, and right now here are 65, but it was 100 5 minutes before on our channel, and a couple of people actually asked me, so I directed them to the YouTube directly. So once we finish our lecture, then only we'll come to know exactly how much people are watch. And this is on YouTube, so people can see this one later on. Those who are not able to see for whatever reasons.
Lovely. I must thank the organizers for this most thrilling and very, very fulfilling opportunity. And the fact that I was the sole speaker made it relatively easy for me to be a little slow and easy without worrying about the bell or the gong or the screen going blank.
Samir,
Can you hear me, sir? Can you hear me?
Yeah, Deshpande sir, yes.
Dr. Srinivas, can you hear me?
Yes.
Yeah.
From here. Sir, is CAFE's disease waning? Because I haven't seen a single case in last 35 years.
So let me make two comments to that. One is that with some degree of sorrow, I have to say that most children, even today, with skeletal complaints, go directly to orthopedic doctors. Okay?
Yes.
So this is a big problem for us. And even in rheumatology, we face it. Very fortunately now that pediatric orthopedics is coming up, so they quickly recognize and refer these patients to pediatric rheumatologists. But by and large, the disease is quite rare. And let me say to you that I started seeing these patients only after I switched to pediatric rheumatology. So in the first 20 years of my practice, I had not seen a single case. So there is some degree of a referral bias which comes up because in a very rare disease, a person may be seeing nothing in 25 years, but now there are 200 odd people who have heard this lecture and got sensitized. So if there is any CAFE who comes in your realm, is likely to be picked up and immediately probably shared, or the history shared with somebody who knows about it or any pediatric rheumatologist, and then you realize it. But there's no reason for it to be a waning disease.
Okay, sir. Thank you.
So should we conclude now? 10:39 now.
Yeah.
Timings. So thanks to Kupchandani sir for excellent talk once again.
Hello.
Hi.
Samir.
Yeah, please go ahead.
Hello.
Yes, you go ahead.
Samir, Dr. Rajendra Vaidya, Aurangabad.
हाँ सर बोला.
आपका वीडियो भी ओपन कर दिया सर. Yes, sir.
Kupchandani sir, good evening.
Hi, Rajendra. How are you?
Fine, sir. Thank you. So just I want one question of the cafe disease. Is there recurrence known once we treat it in later life or anything like that?
Not to the best of my knowledge, Raju, but I will not say that I have this answer with complete certainty. And what I will do is that I will go back, because we had done a little bit of reading on this story and presented this case. I will have to just go back and look, and I will communicate with you. But because my series is too small for me to tell you that I have seen recurrences. But I have definitely read about this fact, and I will try and check it out.
Yeah, that's why I also mean I have not seen. I have hardly seen 2 cases, but I have read there in the latter life there are few cases reported the recurrence. That's why I thought that I should ask you.
Right. I will check out.
Okay. Thank you, sir. Excellent. It's a really great learning experience to hear you always.
Thank you, Raju.
Yeah. Okay. Thank you, sir.
Any other questions? So we should conclude here now. I think so. Jay sir?
Yes, sir. I think thank you, Kupchandani sir, for I can say excellent session, and almost all spectrum of disease rheumatology, almost 30 quiz cases and 10 cases, almost 40 cases we discuss here. And more importantly, you may not sometimes remember the things, but at least you get the stimulus to read and go back, and at least before referring patient to orthopedic, think twice or thrice or 100 times, dig something or refer to the rheumatologist for the further. Today I have seen one case, and I think that was a rheumatology case. I will refer to the rheumatologist then. Thank you very much, sir, for this your time and wonderful time. And we'll come back to you again, maybe later also. Yes.
No, sir. We have on the 27th, that is on the 4th Thursday, we have the intensive care chapter 8:30 p.m. We sit down every month. That is on the 4th of Thursday. Sorry. So this will come on 27th of October. And Kupchandani sir is again coming there as an expert, and he will talk about the rheumatologic emergencies. So that's a talk from the IAP ICC intensive care chapter of IAP. So from that part, we are taking this. So today was a general session for pediatrics. That will be for the intensive care. And I am very sure that sir is going to take another few challenging cases, particularly for the ICU. And please come that time. That will be on 8:30 p.m. onwards on the 4th of Thursday. And this time the topic is on the rheumatology.
Yes, Samir. Thank you. So we are concluding here. Thank you all the audience and this Dr. Vishal, Dr. Neha, and Pallavi madam for this digital support. Thank you, Amol, Dr. Hemant, and all senior CBs and office bearers for wonderful response throughout the year. And we will have some different ideas. I will, and myself and Samir will come with that. Thank you very much. Dhanyavad. Good night. Meet you again.
So Maha IP actually this last year totally done 430 symposiums. So that includes expert talks, PowerPoint presentations. Like what we are doing is a Maha Subspecialty clinic. Every monthly we are asking for one expert in that particular field. And then we have particularly sessions for the parents called Dr. Ek Vicharu. So if you want to see all these ones, all these are available on Maha IAP YouTube channel, MAHA IAP. And you can see there are almost 430 in total. And it's possible that it's not possible every time to watch each and every program. But whenever you get time, you can see them in the past. So go on the Maha IP YouTube channel, subscribe it. So anything coming next, like in the particularly day or like within 1 hour, the buzzer will come up and he will remind you that you have to attend Maha IP channel. So thanks to Gangulia sir and even to Amol Pawar sir, they have been the master behind this part. And thanks to our convener Jaikumar sir for doing these wonderful sessions ongoing. So I hope this will continue for next month also. And afterwards, then we will have the MyIP new people and team will come and continue doing these programs. Thank you, Kupchandani sir, for this wonderful sessions. And
Thank
we'll go to
you.
these sessions now.
Thank you. Good night.
And
Good night.
happy Diwali to everybody well in advance. And
Yes,
we'll
yes.
have that firecrackers of academics this year, and it's going to be